Hey y'all, so I just want to do a quick video about psychiatric emergencies, behavioral emergencies. I know that you guys are turning in your homework tomorrow, so it's really over now, but this is something that's near and dear to my heart for multiple reasons. I've studied a lot about it. I still continue to study about it. I fully believe that one day I will be involved in mental health because it's something that is so special to me. And I take lots of classes on it. I'm currently certified by North Carolina in crisis intervention training. And that's something that I'm very glad that I can do. So I have lots of resources if you need, either for you, for a family member, for a patient. That's something to remember. This isn't just about the patient. This is also recognizing things maybe in you or a loved one or a family member or a child or a parent. There's lots of things that pertain to everybody in general. So please know, and I say this all the time, but I am absolutely serious. You can always call me. If you have any questions, you need resources, you need somebody to talk to, maybe you just need somebody, maybe it's something great, you need something to celebrate with somebody. I'm here, Robin's here. Any of the instructors, I'm sure, would be glad to help you, but please know Robin and I here for you all the way. I know we say that a lot, but I want to make it clear. So I want to preface this by saying that psychiatric emergencies and behavioral emergencies are not always what they seem. Yes, it has a lot to do with mental stuff, behavioral stuff. It can also be a medical emergency that hides what's happening. Well, it's hiding in what's happening, I should say. So I'm gonna try to make this quick because I've tried to make this video 4 times, and first time I didn't like the shirt I was wearing, and the other times my phone ran out of storage, so I'll have to delete some of that. But so psychiatric emergencies and behavioral emergencies can come in many forms. Sometimes it's a true medical emergency, sometimes it's just a mental health emergency, and there's resources that if maybe someone is having a mental crisis at the moment and they just need somebody to talk to and they don't want to go to the hospital, there's lots of resources that you can give them. There's mobile crisis center, there's suicide hotlines, there's Daymark, there's which other counties are probably not Daymark, but that's who we use. Just behavioral health in general. First Health has an excellent behavioral outpatient center. I will say that I myself am a patient there, and I think it's done really great things. You can ask Robin because she's seen me in all kinds of states. But so with behavioral emergencies, please realize that even if you don't think it's an emergency to that patient, it is an emergency. It is something we learned that it means a change in behavior. And if it's not a medical emergency now, it could very well turn into one, or a traumatic emergency. And we don't want to do that. We're here to help people. I have a very strong faith in God. I don't expect anybody else to, and I'm not pushing my religion on anybody else. But as for myself, my own personal belief is that God uses me as a tool to help people. So that's why I'm doing a video on this, even if it's late. I will tell you some very personal things about me. Anyone that knows me well knows that I'm very open and honest, because I firmly believe, and I'm sure you guys have heard me say this, that you grow through what you go through. And I've been through some stuff, and I think if me going through that and being able to come out on the other side and help even just one person, totally worth it to me. So let's talk about some of the mental disorders. I don't even want to call mental disorders. I don't know what the politically correct way to say it is, but psychiatric emergencies or behavioral emergencies. So it could be depression. Depression is a very real thing. Let me go back for a second. I'm sorry, I'm a little scatterbrained tonight. I haven't been feeling well, and they got me on prednisone. But I don't have the Rona, so that's good. So, the treatment for behavioral and psychiatric emergencies has come so far. I'm so proud to live in the United States where, well, even all over the world really, but we have such great medical advancement. In the old times, they used to send people off to insane asylums, prison. That's mostly where they sent them because they thought that they were unfit for society. But, you know, through lots of research and trial and error and medications and different types of therapy, cognitive behavior therapy, there is what's called EMDR, and I've done that before, and it's where you kind of do different things to get your mind off of what's happening at the moment, and it kind of clears your head a little bit. I will say, for me, I have really bad PTSD. I'm currently under treatment for depression, although I don't feel depressed right now, but that's because I have excellent medicine and excellent care and an even more amazing support system. And I have anxiety that kind of stems from both of those. So you will see when I get super nervous, I mess with my hands a lot. You'll see me tap fingers, crack my fingers. That's usually a sign that I'm a little bit agitated, and it's what I use to kind of calm myself down. So there's also lots of medicines that help that. Something you have to be aware of is that there's not one single medicine to help everything even out. So you have to realize that there is a chemical imbalance in the brain, whether that be from genetic predisposition, because we've learned through studies that if you have a long history of people with behavioral and mental disorders, you are a little more predisposed to have them yourself. And it could be from substance abuse. It could be from a medical problem, or it, you know, could be from a traumatic brain injury. There's many other things that it can happen from, and you can read that in the book. I'm sure you all did, right? But so when the brain, the serotonin and the dopamine and the all the feel-good chemicals in your brain, let's talk substance abuse for a second. So you have all these neurotransmitters firing, all these feel-good chemicals going on in your brain. Then you get a drug. That drug comes in there and kind of fogs over the brain. Think of it like a cloud over a tree. So this is your neurotransmitter. And then this drug comes in there and fogs over it. So this tree thinks, well, I've got enough chemicals in this happening in this brain. This is where I need to be, so I'm going to stop making those chemicals. Well, then that drug wears off, and the chemical receptors and transmitters still say, well, I don't need to make those feel-good transmitters anymore because she had enough of them in her brain. So then, when the drugs are away, the brain is still not producing those chemicals to make you feel better. So you need medicine like serotonin reuptake inhibitors, MAOIs. I can't remember what the exact term for that is, but MAOIs, different antidepressants, tricyclic antidepressants, and they help your brain try to achieve that homeostasis. You hear me talk all the time about homeostasis, and it's a give and take. There's not one medicine that makes everybody feel better. Sometimes there's different concoctions of medicines that they have to try. It's really just trial and error to find out what works for that individual person. So what works for one person doesn't always work for the other. Sometimes they just need one medicine. Sometimes they need a medicine called an augmenter to make it better. So augment means to increase or make greater. So they've got a serotonin reuptake inhibitor, and they're going to take an augmenter to make that work a little bit better. And if that works for them, great. They want to stay on that regimen. But if you start missing medicine doses, if you take too much, If maybe they didn't have insurance, so they couldn't get it refilled, so then those chemicals are off. So it's not always just a behavioral thing. It is a very real physiological thing happening to them. So you have to remember that and keep that in mind. So as far as depression, jumping back to depression. So there are two types of stress, right? There is distress, which is bad stress, and there is eustress, which is good stress. So we all need stress in our life. We all have stressors in our life. Take this for example. You guys are in class, you're doing homework, you're going to be doing clinicals, you got your home life going on, you got work life going on. That's a lot of stress on you guys. And we recognize that, and we're thankful that you're willing to go through that with us, and we're here to go through it with you. But so if you use that stress for good, like you have timelines, so you stress yourself out, like I gotta get this homework done, so I'm gonna get it done, then that's good stress, that's eustress, we like that. When it becomes distress is when it starts to have negative effects on you. And it could be in the form of losing sleep, sleeping too much, eating your feelings. That's me. My divorce was not nice to me. I ate my feelings, still do. I love bread. But you could have suicidal thoughts. You could just feel depressed, lonely. Some people they use it to the extreme, and they keep themselves so busy working multiple jobs and doing things so that way they don't have time to think about, negative things. Also guilty. But if that person's depression does not get adjusted and helped, they could become suicidal. And maybe you don't see it, but you get on scene, you've known that patient for 5 minutes. That family's known them forever. They know when something's wrong. And you can look at their body language. Are they withdrawn? Are they sad, tearful? Do they not want to talk to you? Do they want to talk too much? You can pick up on body cues. We're all adults. We can read people's body cues, like most of the time. I mean, I would hope. But they'll give little signs, even if they're not verbalizing, they'll give little signs that they're in distress. So just be there for them. Sometimes it may just be like, hey man, I'm here if you want to talk. If you don't want to talk, that's cool too. But try to make sure to get a physical assessment on them if they will let you, so that way you can determine whether it's a medical emergency or just a mental emergency, or both. Maybe they're hypoglycemic. Sometimes they can be super violent when they're hypoglycemic. Seen it many times. Maybe they have a head injury. Maybe they're postictal from a seizure. There could be lots of things. Maybe they're coming off of alcohol. Maybe they're coming off of drugs. Maybe they're on drugs. You have to get a good HPI sample history in order to determine that. So vitals are important. I'll leave that there. So schizophrenia, very real. When I was in my crisis intervention class, there's a guy here in this county, and I wish that he could come talk to you guys, but I don't know really how well that would come out. But he honestly thought that he heard voices to say cut his hand off so that way he wouldn't do evil. And he literally cut his hand off with a table saw and then held it in place, but he said the voices were telling him that. So if somebody says, hey, they're hearing voices, maybe they say, I just have this on my dresser because I really like it. So maybe they see spiders on the wall. If somebody's telling you that, don't try to swat the spiders, play into it. That's not a good thing. Distract them. Get them talking about something else. Don't play into it, because that could just make it so much worse. And remember, if they already have that problem and they're under the influence of alcohol or drugs, it's going to be 10 times worse. So I'm going to get to PTSD and suicide in a minute, but bipolar disorder. So that's when somebody is up for a really long time. They got lots of energy, go, maybe talking a mile a minute, And then they just hit a point where then they're low. They just want to sleep. They don't want to do anything. They're depressed. I mean, it's usually managed by medicine very well. So make sure that they're taking their medicine. Be compassionate. Be kind. Please, I am begging you. Like, they need somebody. And you never know if you're that one person that they needed to be right there, right then, to handle it. I don't know about you guys. I think everything happens for a reason. And I just thank God that I can be there for people, because if paramedics weren't there for my son, if those paramedics that were skilled and knowledgeable and compassionate and wanted to tell me everything that was going on, if those people were not there right then, my son wouldn't be here. I probably wouldn't be doing this. There's no telling where I would be. But now I'm passing that on, and it's an honor to pass that on to other people in hopes that maybe someday they will pass it on, be the change you want to see in the world, all that good stuff. But let's talk about depression, suicide, PTSD a little more. So when we talk about depression, this is, I've said it before, this is not just about your patient. It could be about you. It could be about your family member, coworker, somebody that you love. We see things in this field that are horrible. We don't wish it upon anybody. Some people can't take it. If you feel yourself going in a downward spiral, please reach out. Somebody's always here for you. I promise you. And recognize before, if you're losing sleep and you can't concentrate and you're having really bad thoughts, or maybe you just want to sleep too much, recognize that those are signs that there's something going on. Even if you can't tell right here, sometimes your body just gives those physical signs. Increased heart rate, constricted pupils, lots of sweating, internal body temperature goes up, stuff like that. It's signs that there's a problem, and reach out. PTSD, have it, very real. Was never in the military. People joke about it, but it's a serious thing. Those veterans, those people that have been through that existential crisis that is life-changing forever, they get back in that place. Smells, sights, things like that. It happens. I can't remember if I talked about that on this video or the other video that cut off, so I'm really sorry if I talk about things twice. But let's talk about something that is also very near and dear to my heart. I will tell you, I've seen way too many suicides. And the suicides are not what I would think before I started this career would be. It's not 20-year-olds that are having girlfriend problems. It's not, I mean, you do see those, but not as much. It's not people who have been fired for their jobs. It's elderly. And I get very emotional about this, so I'm very sorry. It's older women and men who maybe they have dementia, maybe they have end-stage cancer, or maybe they're just losing their mobility, they're losing their eyesight, they're losing their hearing, and they are afraid that they will lose their independence. They're afraid that their family's going to send them to a nursing home. They're afraid that they won't be able to even wipe their own rear end. There are people who have a lot of pride, and I don't blame them. Same way. I tell Robin all the time, she, by the way, is like my power of attorney, so if anything happens to me, she gets to make those decisions. But nobody wants to live where they can't take care of themselves. Like,